Hello, and welcome to the PAH Initiative podcast. This podcast is sponsored by, and the presenters are being compensated by United Therapeutics. In this series of podcasts, we'll talk about how PAH treatment guidelines and risk calculation drive treatment decisions in PAH, as well as our own experiences in treating our patients with PAH. I'm Dr. Vallerie McLaughlin, and I'm joined today by my good friend and colleague, Dr. Ray Benza. Ray?
Good day, everyone. Val, it's a pleasure to be here speaking with you again on this very important topic.
Yeah, thanks, Ray. It's always a pleasure. As you know, in our previous podcast, we discussed the importance of frequent risk assessment and timely treatment escalation. So we talked about that from our physician and PH treater viewpoint. But today, we would like to discuss the conversations that we have with our patients who have PAH, including the discussions around risk assessment, treatment escalation, and their prognosis. So let's talk about those conversations that we have with our patients. You know, we see them, we assess their symptoms, we talk to them about their therapies, and we risk assess them. And that really drives our monitoring and our treatment of our patients. So, Ray, tell me how you talk to your patients about their risk status and why low risk is such a critical treatment goal and how we get there.
Yeah, thanks for asking that, Val. I think that's probably one of the most crucial things that we do with our patient engagements in clinic. It's really important for them to understand the strength of risk stratification and how it really drives our methods of management for their disease. And usually, what I try to do is I try to have them understand how all the tests that they do come together to really develop a firm prognosis on how they do with their disease. So all these tests that they get, their walk tests, their functional class assessments, their blood work, their echo, their pulmonary function studies, and even their hemodynamics, how they all fit together into one unifying picture. And they paint that prognosis to their physicians, who then gauge their therapies on that. So I typically will show them some of the tools that we use to assess their risk. In our clinic, we typically use the Reveal calculator, and I show them how we plug in all the information that we've gathered about them into that calculator and how it spits out a specific risk of their 1-year survival and morbidity associated with that disease. Sometimes patients are even interested in seeing what their survival curves look like and how, as they move from one score to another, how that prognosis can either become more poor or even improve as their therapy changes the course of their disease.
Yeah, so I think that's great, Ray. One important component of any of these tools is functional class. Now, as we talk to a patient about their functional class, there is some subjectivity to that. Can you tell me how you assess a functional class on your patient during a visit?
Yeah, this is really interesting, and I think it's such an intuitive question because we usually have a pattern of asking what limitations a patient has in their daily lives. And they always wonder why we ask them all those questions until you show them how it comes together to develop this functional class assessment, which is an integral part of all the assessment tools that we talked about earlier on some of our podcasts. And typically, I will usually ask a patient, are you short of breath when you're speaking to me, which assesses really how a patient breathes at rest. If they're watching the television, are they short of breath? If you're sitting at the table reading a book, are you short of breath? And then I will ask them increasing levels of exercise to really get an idea where their breathlessness starts. For example, do you get short of breath showering or shaving, or putting your makeup on, or doing your hair, or dressing, activities that represent daily activities of living. I'll then ask them, can you walk a block? Can you walk a flight of stairs? And with each progressive increase in activity where they develop breathlessness, I correlate that with their functional class, so that if they're short of breath at rest, they're a functional class 4. If they're short of breath doing their daily activities of living, they're a functional class 3. If they're short of breath walking a block or a flight of stairs, but okay at rest and with their daily activities of living, That's a functional class 2. And if they have no shortness of breath with any of their activities, that's a functional class 1.
So that's interesting, Ray. I mean, that just shows you the subjectivity. I approach it in a way that's very similar to you, starting with a low level exertion and gradually going up. But I have different cut points than you do. You know, a block or a flight of stairs. If they get short of breath with that, I'll call them a 3. I would expect most patients that's an ordinary activity that they should do. It's really the second flight of stairs that I would call them a 2. But I think the key is as long as you're doing it consistently within your practice, that tells you the difference from one visit to another. So I think the other important thing with functional class is really what does the patient do? I think we all have some couch potatoes in our practice or some people who have just limited themselves so much that they'll tell you they don't get short of breath with anything, but they really don't do much besides walk around their house. Like, how do you really tease that out when the patients have a very limited activity level from the start?
Yeah, I think these are where some objective measurements are become very useful. We've developed, surveys that patients can take while they're in the waiting room, which describe a whole level of different activities that they can check off to see whether they have shortness of breath or not. That way, it's the patient's opinion, but you judge based on these various levels of activities what they can and cannot do, and can maybe judge from that their functional class. And there are other ways to do it, but when I agree with you. There are a number of patients who really sit around and don't do much activity during the day, and that's where other tools may come in to be very helpful. Whether they use activity monitors or things like that, they give us an idea of how much functional activity they do per day, and if they are really sedentary, then sometimes a more functional assessment is necessary to really get at their level of breathlessness.
Yeah, I think those are great points, Ray. You mentioned earlier that you discuss prognosis and you show survival curves to patients. Can you explain to me how you describe that to patients and what their response is? I think that we all have challenges talking about issues like that. You know, we want to bring hope to the patient. We want to talk in a positive way, but sometimes those curves are very enlightening. Tell me how you approach that and what the patient's responses are.
So these are the nice things to have some sort of technology in the room with you. We do a lot of these discussions using our iPads, and we use animation on these curves so that we could say, this is where you are right now, and this is what we would expect you to survive if we did nothing to you. But this is where we want to get you. And then I keep showing them the animated improved scores and curves associated with those. And I said, this is what we can do as we add therapies and if you respond to them. And that does give them a lot of hope that, wow, I can really improve my score and I can improve my prognosis. And I think that really brings them into, really understanding their disease state and why we push so hard to achieve the low risk status, because that's where we show we want to get them. So here's your curve. Here's where we want to get you. And we can do it by using thoughtful medications and additions, having you watch your exercise tolerance and report it to us accurately, and those type of things. And I think that really gets them engaged in the conversation.
Yeah, I think that's really a great point. You know, so often we treat patients and they feel better. They think about their short-term goals and now they're able to function better. Maybe even their functional class and their hall walk has improved, but maybe they're still not really at low risk. But honestly, they're happy with how they've improved in their quality of life. And sometimes these conversations are the most difficult. The patient thinks they're doing fine, and maybe they are in the short term, but we need to really explain the long term goals to them. Tell me how you approach that conversation, both in terms of risk assessment and explaining long term goals, but then also making that confident recommendation to them about an incremental therapy.
Yeah, wow, that is a really, again, another insightful question. I think that's how I kind of move the conversation, is by talking about survival. And as you mentioned, maybe survival is not something that a patient is most interested in. They're more interested in quality of life. And so then I try to move the conversation from survival to morbidity, including hospitalizations or the risk of hospitalizations for heart failure or pulmonary hypertension related heart failure. And I think most patients would agree that they don't want to be hospitalized, and that would negatively impact on their quality of life. So that when you show them that there is an association between their risk level and the risk of them being hospitalized, well, that brings a few more patients into the equation.
Yeah, I think those are all great points, Ray. And I think we also have to remember the shared decision making paradigm, but how valuable as well our insight is for the patient, right? So we are always balancing risks and benefits. And as we talk to patients about some of these more advanced therapies, if they're not at low risk status, we need to weigh all of that. We need to talk about the potential benefits in terms of long-term outcomes, improving symptoms. We have to be honest with them about the potential side effects of these medications and the tools that we have to manage those side effects. But then we really need to stress the fact that we are recommending this because we think it's in their best interests long term, that we think it's going to improve their symptoms, quality of life, morbidity, and really make that confident recommendation to them. They rely very heavily on us for that.
I agree. And I really think all the questions that you asked were so insightful today. And I would like to thank everyone in the audience for joining us today as we reviewed how we talk to our patients about different topics in pulmonary arterial hypertension. And I would also ask them to be on the lookout for more podcasts where we will discuss important topics in the PAH space.
Great. Thanks, Ray. A pleasure working with you as always.
Same here, Val.
If you would like more information on risk assessment, PAH treatment guidelines, or to use an online risk calculator, please visit pahinitiative.com/HCP.